I lost my brothers, I lost my sisters, I lost my best friends.
The gravediggers are volunteers. They've each lost a number of loved ones.
2. My mother, my son, and my father.
Likewise myself, because he's my elder brother. 5. 3.
4 good people, 4 good people.
Thank you so much to be on this panel with Raj and with Naeed. And I want to start, Raj, you actually won the TED Prize recently for your work that your Last Mile Health group is doing around training community healthcare workers. And we actually have a video featuring one of them. I'd like to start and take a look at that first.
While I was doing my restock, on my way, I heard a sound behind me. And when I stood up, and I said, who yelled my name? From there, a girl came, she said, oh, someone is dying, but we need you quick. So the medicine bag was on my back, and I turned around, we're running. When we entered in the town, this little child was jerking, what they call convulsion. She started jerking. I myself carried her to Pool River Clinic. So there where she get her treatment, and then she was fine by the grace of God.
Thank you. You were both involved in the response to Ebola. Could you talk, maybe Naeed, you first, what was it like actually to be there on the ground? This is by far the worst Ebola outbreak in history. 11,000 people died. Just give us a sense of what it was like to try to help, try to be a caretaker there.
Sure. So I worked as a Ebola treatment unit clinician for off and on for over 5 trips, or 4 trips, I should say. And the biggest thing that I can tell you is 3 components of this, where I saw maybe 500 Ebola patients, and I lost 60% of my patients. And what is the most disheartening part of this is they died for very preventable things. I mean, the lack of amount of human resources and physical resources, particularly in the summer of 2014, was so drastic. The second component of this was an interesting place for healthcare workers to be, because you had to manage your safety with patient survival. Someone said it best recently, I think, that Ebola was like going to war, but you didn't know where the enemy was coming from. And watching your own healthcare workers, and particularly for national healthcare workers, I mean, Kenema, the first place where I served, lost 35 healthcare workers, including their last doctor who died under my care. So it's just disheartening in these communities.
Mm-hmm. Raj, for you, I mean, your Last Mile Health started in Liberia, obviously ground zero for Ebola. How did it affect your group?
Well, we had been there since 2007, and I had a chance to grow up in Liberia. We had a number of our health workers who'd lost their teachers in the city. And then we work in remote rural areas where, of course, this disease started in a rainforest in Guinea with the 2-year-old who first fell ill. And so we're working in places where the roads are sparse and there are massive shortages of health workers. And so a large part of our response, working collaboratively with our Ministry of Health, and I don't know if Gary Gottlieb's here from Partners in Health, but a number of folks, including GE, were all involved in this, but essentially trying to train and equip community members from the areas where the disease was affecting people in Riversess County, rural Liberia. A woman there had come with Ebola, 42 years old. This is, by the way, 10 months into the epidemic, and the community had not yet gotten the message that about safe burials, and they didn't have any health workers to do that. So here's a woman who shows up with Ebola from the city, having not been able to get into an Ebola treatment unit because there were no beds, did what a lot of us would do, go to our safety of our family. Hers happened to be 10 hours into the rainforest. She dies, 14 of her relatives attend a funeral. 14 days later, 14 of them, of the few dozen that attended, had died. And they're 5 hours away from the nearest hospital. So how do you, in those moments, deliver health care, making sure that both those who are sick and exposed to the virus get into care. So we were supporting the Ministry of Health to deploy lab technicians who left the hospital setting and would go into the field. Imagine wearing the suits, the hazmat suits, and to go into the field and actually draw blood samples door to door in a very uncontrolled environment. So working with 24-year-olds like David in that particular case and supporting them was critical in stopping outbreaks in remote settings. Of course, our colleagues at MSF and the CDC were really critical in this. So it was really all big effort in remote rural areas. Maybe last thing I'll just add, Bryan, and turn it back to you, is I think one issue that's not been really focused on enough is Ebola's shadow. Mm-hmm. So even in places where the outbreak didn't occur, in Liberia or throughout West Africa, you saw the ripples of Ebola. We did a study that showed you were 40% less likely to go and deliver a baby in a clinic, even if there was no Ebola transmission in your community, if you perceived you could catch Ebola from the clinics. So that was a real challenge. Probably more kids have died from malaria, tuberculosis, HIV because the health system was disrupted. A lot of us in this room were involved, I know, in trying to keep that health system going. And that's still a big issue now, to make sure the next outbreak is caught early.
So that 11,000 figure was almost certainly just the tip of the iceberg in terms of the overall impact of a disease like Ebola. So what do we take from this? Because this is not going to be the last time we face this disease. There will be other ones out there, ones we know about, and probably more frightening diseases we don't know about yet, we haven't discovered yet. So what lessons should we take as a global health community to make sure that we're better prepared the next time we face this?
Yeah, I think we're a culture of outbreak response. At best, we are a culture of outbreak preparedness, but we are not a culture of outbreak prevention. We seem to chase one pathogen after another. It's Ebola, then it's Zika, and then it's yellow fever. And the truth is, pennies on the dollar, if you could invest in some of the basic things that really allow continuous surveillance for infectious diseases in communities, you would actually increase that yield and catch everything that comes along. I find it interesting that your organization is Last Mile Health, because I always talk about the fact that at the terminal end of all international surveillance for infectious diseases are communities that have no access to care. I mean, the way surveillance works is there's a cluster of people who get sick. They go to healthcare. The clinician picks up the fact that there's something abnormal. The clinician reports it somewhere up to a functioning public health system. Then that public health system responds up to WHO, and the alarm bells go off, and there's an efficient response, right, within the country and WHO. But that first mile or last mile, however you want to put it, majority of the people are not getting to care. And if they are, one thing that sort of makes a lot of people surprised when I speak about this is that in resource-limited settings, you are diagnosed by treatment. You go in, you have a clinical syndrome of some sort, and they give you malaria medication. If you don't get better, then they say, oh, it might be something else. Maybe it's typhoid, right? Because of that, there's a built-in delay for us to pick up outbreaks or clusters before they become outbreaks.
Yeah. Well said. I think I'd build on your point in terms of lessons learned. Look, if we still can't learn the lesson from the first patient, Emil, patient 0, right? 2-year-old boy who gets sick with fever, vomiting, and diarrhea December 2013 in the rainforest across the border from where Nahid and I were working in southern Guinea. He dies December 2013. A few weeks later, his sister dies. A few weeks later, his mother dies. And this mysterious disease at the time would spread from one community to another in the rainforest borderlands between these countries, Sierra Leone, Liberia, and Guinea. And it wasn't until 3 months later, in March 2014, when this was identified as Ebola. Right? When every minute counted, we're losing months. When every year counted with HIV disease, we lost decades. In the case of Zika, we've lost many years as well to understand this disease. Every one of those illnesses were zoonotic diseases starting in animal reservoirs. Those animals are interacting with human populations in forest communities, all in the same rainforest belt throughout West and Central Africa in these particular cases. The amount of loss of life, the amount of billions of dollars that's cost the economies have been tremendous. And if you ask what is common, well, one issue is that 60 to 75% of new emerging infectious diseases are zoonotic. And if you ask, then what else is common is, in addition to epidemiology of disease, is the investments in healthcare. There's been as our friend Paul Farmer would call it, a clinical desert in these settings, right? Where there's just not enough investment going to these places, and you're seeing massive costs from it. I mean, that one child, his disease killed him, killed his family, killed a number of communities. It wasn't until March 2014 we caught it. It spread like wildfire across West Africa, reached the shores of this country, cost billions of dollars. We lost 500 health workers in our 3 countries in places where there were things like 50 doctors after the war. And companies shut down. Airlines started cutting off their routes to West Africa. So, there's a real consequence of not investing in the basic idea of getting health care for everyone everywhere. And it turns out, probably one of the big lessons is that blind spots in rural healthcare can lead to hotspots of disease. That places us all at greater risk. And the most efficient emergency system might actually be an everyday healthcare system that reaches rural communities like Emil's in the first place. And our challenge is, are we willing to invest in the private, public, and nonprofit sectors in those communities?
And I want to add to that for a second. It's interesting because why was the Ebola epidemic inevitable at the level that it was? And if you don't invest in those health systems and the first responders, everything is going to be exogenous. Everything will have to be brought in, laboratory capacity, healthcare workers, so that's a built-in delay. Again, anyone who was working in the field in summer of 2014 was not surprised by either the fact that the mortality was high as it was, or the fact that the epidemic was out of control, because really, the way you control an epidemic is you isolate people who have disease, you quarantine people who are exposed to it, right? And you make sure more people don't get exposed to it. But we didn't have enough beds to isolate people in the Ebola treatment units. And here's the crazy thing, right? People would come to the Ebola treatment unit because they fit the clinical description of Ebola. Clinical description of Ebola is fever, nausea, vomiting. For the most part, is how people presented. Everything looks like fever, nausea, vomiting, diarrhea in West Africa. And so you would put people with malaria, you would people with typhoid into the suspect ward, wait until they're confirmed, and then put them in the confirmed ward. It took about 3 days to get laboratory results back. So people were sitting around. If they didn't have Ebola before, we gave them Ebola in ETU units, or in ETU Ebola treatment units until they left, then got sick in their communities, right? And just the dearth of care. The mortality in expats was less than 25%. People who were returning responders who got sick, who were brought back. The mortality in most ETUs were 60 to 70%. And yes, somewhere in between, maybe expats are a little healthier and things like that, but that was a description of how where you're born decides how you die of a disease. And it was really the lack of resources, I think, more than anything else.
I'm going to open up to questions in a moment, so if you want to make yourself known to the microphone handlers, please do. We didn't have a vaccine or a treatment for Ebola or for Zika, but these are not new diseases. Now, Bill Gates and others have sort of put a lot of money behind the CEPI Alliance to begin to more rapidly develop vaccines for some of these forgotten diseases, both Ebola, Lassa fever, also technologies for future vaccines. Is that enough? Given that there's not really pharma companies are probably not going to be, they may respond to an emergency, but I can't see them investing beforehand. Do you think that this is going to make a difference, Raj?
I think it's certainly part of the answer. That investment has to be there. If we had Ebola rapid tests, if we had a vaccine earlier when this crisis happened, we could have potentially averted a lot of the impact from it. I think obviously the big other piece of this, in addition to technology, is making sure that the providers are there in these places. And I know we talked pretty in a gloomy way about what happened, but there are solutions. 10,000 community members were mobilized during this crisis in Liberia alone to learn the signs and symptoms of Ebola. These are 8th to 12th grade educated people who learned the symptoms and signs, worked with doctors and nurses to find the sick, get them into care, to track thousands who had been exposed, help break the chain of transmission, and literally hunt down the virus and stop it in its tracks. Those same community members now are being invested in as so-called community health workers by the Liberian government. The Sierra Leonean government's trying to do it. That the goal there is to get a health worker in place for everyone everywhere who is trained. The first training they're getting, and we've helped the Liberian government with this along with the CDC, is to record unusual deaths or just any death and why it happened. And so many deaths have been anonymous to the healthcare system. So having an army of community health workers is one key additional solution. That has to be tied into great referral systems, including clinics and hospitals and lab systems. Once these workers identify, say we just found in a remote setting that's about 20 hours away from the nearest hospital, an outbreak of acute watery diarrhea. Well, how quickly will we test these people for cholera, right? You can't test for cholera right there. You've got to have a great lab system that's back up. So I think investing in the people, the systems behind it, and measuring that is critical. So
the second component of that is, CEPI is fantastic as a model for what other companies and other funders can do, but CEPI takes a product all the way up to phase 2 and phase 3. You still have to wait till there's an outbreak to test out the efficacy of that vaccine. So you need a research infrastructure. You need minimum amount of capacity to carry out trials in an ethical way. And we were lucky with Ebola. We already had a vaccine because DoD had invested so much with Ebola. We may not with the next emerging pathogen.
I think we have a question down there.
Hi, my name is Matt Cook. I have a regenerative medicine practice that's mostly based on stem cells and injections. But I know quite a bit about something that's going to sound sort of off the wall, but it's called ozone therapy. And a friend of mine went to the Ebola outbreak and treated a bunch of people and cured a handful of them with ozone therapy. And it's a common therapy used across Europe and Italy, Germany, and Russia. And it has fairly profound antiviral effects. And
do you have a question?
Well, just to mention it because it's a possible therapeutic modality that costs pennies that could be deployed in a system like this. So it's just throwing it out there. I don't know if you've ever even heard of it.
Yes?
No, but it does bring back to me, when you brought that up, the thing that I was thinking of is the ethics of research in outbreak setting. That was a major concern for us for a lot of interventions, right? And so any new innovation that you're introducing in the field, you have to sort of put it against the wall of these are people who are facing about 60 to 70% mortality. That's a lot of duress. So what is informed consent in that setting?
I'm just relieved we have an infectious disease specialist on the panel.
I think we have down there.
Yes, thank you. It's Dan Zimmerman with Reinsurance Group of America. I'm reading Mike Osterholm's book right now, Deadliest Enemy, which if anyone hasn't read it yet or is reading it, it's a little sensationalistic, but maybe not. I think it tells a great story. But I want to ask you about one of the points he makes is that you can have all this science, but you have to have policy behind it. And can you speak to a little bit how important that is, whether it's government, private enterprise, whomever, that has to develop this policy in order to make the science successful?
Yeah. Well, first of all, I want to thank your company because I believe you guys have worked a bit on this pandemic financing facility, or I may have that wrong, but the insurance companies have worked with the World Bank on developing this financing facility that's supposed to trigger more quickly when potential pandemic threats arise, provide the support. And I think in terms of private sector involvement, that's key. In terms of policy, we've seen a change in policy that's been absolutely critical in Liberia to help keep us safer and from the next epidemic. And I'll give you an example, the one I know well. We train and professionalize community health workers and link them with nurses. So before the crisis, every one of Liberia's community health workers were volunteers, which meant that they didn't get paid, which also meant that they didn't get supervised, which meant they also didn't get equipped well. In a lot of settings, when Ebola hit, those community health workers, which were providing some vital services, were told to stop working because they didn't have the gloves, gowns, and masks to keep them protected. They weren't being coached. They weren't being supervised. No one could tell whether they were actually on the job or not. Following the crisis, the Liberian government has put forward a policy that they approved about 7 months after the last case, which is to actually train, equip, and pay these community health workers and develop a national community health assistant program, as it's called in Liberia. Goals are simple. 4,000 trained, equipped, paid community members to be primary care workers, with 400 or so nurses and physician assistants to coach those workers that are based out of clinics. Why are they doing that? Because the first module they want to train on is actually on infectious disease surveillance. So I think that kind of investment, now, will the investment come is another question. Right now, that's being supported partly by domestic financing, public dollars, partly by foreign aid. It cost about tens of millions of dollars, like $11, $12 million at full scale to support a program like that could help prevent billions of dollars of loss. But getting the financing, these countries to actually, I don't know if Jeff Walker's here from the Financing Alliance at the UN, but Liberia, Sierra Leone's trying to do something similar. A number of these countries where the majority of the threat and the risk is in are not getting the financing to deliver on these everyday healthcare systems, workers like this one. And you're talking about peanuts on the dollar, or cents on the dollar. I immigrated here when I was 9, so I mess up American colloquialisms every now and then. But cents on the dollar, to make this happen. I think the urgency that some of you in this room I know understand to drive behind that kind of policy effort when the leadership is there. Liberia's not the only one. Sierra Leone, Malawi, Kenya, Rwanda. But is there enough backing and support? I think it's a big question.
Time for, I think, just one more question, which I'll take. The current president, before he was the president, he was a tweeter. During the Ebola crisis, he tweeted a number of times, among other things, saying that American healthcare workers who had gone to treat Ebola patients in West Africa should not be allowed back in. Are you concerned, or perhaps what impact would it have, to close borders in that way? Because I could certainly see that's a reaction. People have that reaction. He wasn't the only one who had that reaction. So when we're trying to fight infectious disease, whether it's Ebola, whether it's something else, why is it that closing borders in that way would be counterproductive?
Yeah, I was actually coming out of one of my shifts from ETU, and I turn on the TV and I see Donald Trump saying, oh, they shouldn't be brought back. It was very personal to me when I heard that. I think one of the least helpful terms that came out of this was abundance of caution. People don't realize that abundance of caution carries its own weight. One was, through abundance of caution, airlines stopped flying, the consumer suppliers stopped shipping. We started running out of personal protective equipment in the field. There was a week in August where we cut up tarp to wear aprons. So our choices were do that and go in, or not go in, and there are 100-something patients that get no care. It has a direct impact when you change trade and travel, right? It also decreased the number of people coming in to volunteer. It has an immense impact.
Okay, Raj.
Yeah, as far as last time I reviewed the literature, you can't bomb Ebola, you can't pull up a wall to stop Ebola, and you can't really close borders to stop Ebola. So the science doesn't support it. I think the good news is science does support other things that the CDC has been really great about: prevent, detect, and respond. And Nahida echoed that earlier. I think, as we look at right now the cutback in foreign aid and foreign assistance that's being proposed, I think one of the places where we would really hurt ourselves would be to ignore the signals that have come from Ebola. Creating jobs for primary healthcare workers and equipping them in rural settings in Africa would be a great security initiative if that's all you cared about. Of course, there's so many other reasons to do it. So you can't bomb Ebola as the
Can't bomb Ebola. Take that away. Thank you very much, both of you. It was a great panel. Thanks.
Thank you. Thanks, Brian.